Good morning. How is everyone? Now, Mike Selby here, just running the virtual Global Spine Conference today from Adelaide, South Australia, where it's morning time. Good evening to my colleagues in the US, Europe, everywhere else over the world. We've got Wendy here. She's one of the founders of the conference, and she's helping me out today. A lot of the regular panel are in the operating room tonight, so they're doing cases. So I'm sure we'll hear about that a bit later. But Ali has just asked me to run through a few spine deformity cases, and I thought I'd keep it regularly, sort of more regular cases, a little bit interactive, so people can fire questions through. I think, Wendy, are you there?
Yeah. I'm here.
Are you happy?
Yes.
Are you happy to have a look at the chat box? Because
I will do it, and I'll let you know when there are questions here.
No problems. Thank you. All right. So I think we'll get right into it. I'm just going to get this talk going. Okay. So this is when we look at adult spine deformity, and I know not everyone on these conferences are spine surgeons. So I just thought I'd go back to basics. And this is a picture from the SRS manual, which is worth a download if you haven't done it already. But it's basically available free via the SRS website. So the sagittal balance, when we're looking from the side of the spine, is there are lots of different ways of measuring it. The most simple way is to measure a line from the middle of the vertebral body of C7 straight down and measure from the back of the disc at L5S1 or the S1 end plate to that line. So that's that X in that diagram we've got there. And this is a really important parameter, and it's correlated with a lot of quality of life measures and other things. But I think it took a bit of time as spine surgeons for us to work out that this is in fact an aged matched SVA. And so naturally we all lean forward a bit more as life goes on. And I've said before, but E equals MC squared is a very famous equation. In spine surgery, it's equivalent is this equation here. And it's SVA equals 2 times, in brackets, age minus 55 plus 25. And it's quite complicated. It's derived from a line of best fit from the work of the International Spine Study Group, which are a big group of surgeons that have got a lot of data on spine deformity. And I think when these concepts were first created, we ended up with a lot of patients who had a mismatch, and they were elderly, and we perhaps did too much work in terms of restoration of lumbar lordosis. So found that we actually had problems like PJK, rod breakage, non-unions, all sorts of bad things happening because we were probably being too aggressive for some of these elderly patients, really trying to match them up. And so my patient there on the right of screen, they were quite positive, I think about 125 mils positive. We've got them back to about 75 mils positive, which for someone who's 75 years of age is approximately correct. I've got a more detailed case coming up. Okay, so this is a 77-year-old patient with a degenerative kyphoscoliosis. Her starting SVA is 100 millimeters. Her expected age match SVA is 73 millimeters. And I can't do the numbers in my head. I have to get my calculator out because I'm not a neurosurgeon, I'm an orthopedic surgeon. So I get the equation out every time and plug the numbers in. And this was what I did for her. So she's had my quite common construct in my hands, a T9 to pelvis, posterior instrumentation, supplemented initially by a 2-level anterior fusion to secure the base and get rid of that lordosis back through the bottom segments. This is something that I have looked at over many years as to what to do with the thoracic curve. If you see that she's got a bit of an elevated upper thoracic kyphosis there, but when she was lying on the supine MRI, and I'm sorry I haven't included it for this particular case, but that's examples coming up, I found that she corrected quite nicely. So she's still got a somewhat flexible upper thoracic spine. There is a bit more morbidity, I find, going to T4. It's a longer operation in an elderly patient. And so I try to go to T9 where I can. I know a lot of people stop at T10. It'd be good to get people's thoughts on that at some point, but I tend to stop at T9 with sublaminar bands and T10 on my pedicle screws as my version of a soft landing. So this lady at 6 months post-op, 6 weeks post-op, had a pretty good result. She was well balanced overall, and but she was still positive. She was about 70 mil SVA, which is around the mark. Interestingly, we got her doing a series of exercises, and this is a 2-year post-op film. So her expected age match SVA again is 73 mils, and I think down here she's down to about 48 millimeters. So I wouldn't say she's overcorrected. She's certainly still positive. I think her balance is good here, and overall quite happy with this result.
Hey, Mike, can I ask you a quick question before we go to the next one? Did you just say you had her do some exercises to get this, to help with this?
Yeah, a lot of these patients get, I mean, I don't think it was bad, the initial 6-week x-ray, but a lot of these patients get a lot of muscle spasm post-op in the upper thoracic region. It's the remaining mobile region of the spine. And as their pain decreases after these big surgeries, they're allowed, you know, I get them really doing extension-based exercise with PT, yeah, they improve their upper thoracic musculature. They stop leaning forward as much, and this is a really important part of the rehab process for me. I can't prove it reduces complications, but I think it helps. And you see some x-rays like this, and I think at 6 weeks, if I go back one, yeah, she's leaning forward a little bit more. And yeah, as part of that is pain inhibition. A lot of patients are just coming off their painkillers at that point. They haven't done a lot of rigorous exercise because their incision and muscles are still healing underneath. So she's an interesting one, and she actually got better after 6 weeks. And I think, you know, overall she's been pretty happy out to 2 years, or very happy actually. So it's a good result, but it's a relatively, I don't think that's a particularly difficult curve or difficult concept, but I think the trick is to try to get the SVA roughly right for the age and not overcorrect these older patients. Alrighty, so we then get to a challenge. This is a retired family doctor, or GP, we call them in Australia. She's 75. She's recently retired, had lower back pain for many years, and she can't stand up straight. She's got a degenerative lumbar kyphoscoliosis. She gets some leg pain from foraminal stenosis. Central stenosis is only mild, and she's got a VAS in her leg of 5 out of 10 and back out of 9 out of 10. And this is a misleading EOS scan because she reported to me that she couldn't stand up straight in the scan, and she sort of had her elbow supported on the side of the EOS scanner. And I don't know if anyone here has ever been in or seen an EOS scanner, but they're sort of like a telephone booth, an advanced looking telephone booth you step in. And so the patients can actually lean on the side kind of accidentally. And if you do side bending x-rays in them for, say, idiopathic scoliosis assessment, patients do get limited by how far you can bend either side. So it's a great piece of equipment, but it does have limitations. And sometimes patients are almost holding themselves up on the scanner like she was. So she's got a decompensated posture there. Her SVA is 126 millimeters, which is, again, well above what should be, around 75. But she's got a coronal shift to the right here of 78 millimeters. So this is a significant shift from the midline. Her CSLV is off, and that basically results in a reduction in the ability of the body to cope with day-to-day life due to a lot of pain mechanisms associated with that. She's got a reduced lumbar lordosis. She's got a reasonable thoracic kyphosis. Pelvic incidence is 52, so average, and pelvic tilt is 29. And you can see the MRI there. This is an example of what I was talking about. The MRI shows a reasonable correction of her upper thoracic kyphosis, so she's flexible. So I think that by correcting her primary lumbar problem and her lack of lordosis, as well as a coronal shift, which is down there, that we should get a reasonable result without having to extend her up as high as T2 or T4. This is a more detailed X-ray from a couple of years before that, which just shows the degenerative changes in the lower back that have gone on to decompensate and progress. So what else do you need to know? Look, I think with these patients, these elderly patients, it's very important that we know their bone mineral density. And this is a spine bone mineral density, and she was osteoporotic. And she was osteopenic in her other radius and hip. And I think with this in mind, it's certainly worth a chat to endocrinologist if you're friendly with one, or getting access to Forteo, which I used for her. Forteo is, I think, a bit harder to get in Australia than some other international centres. Parathyroid hormone analog, it builds the bone quite rapidly. You can start it before surgery and keep going afterwards for a total period of 18 months. I got some advice from this very conference on starting it about 3 to 4 months before the operations and then continuing it after that for a total period of 18 months, both pre and then post the procedure. And the other interesting thing is that, I'll go back a slide, she'd had a knee replacement complicated by a DVT as well. So she is fit, active, well patient, but she has a little bit of medical history we had to deal with. So she went on Forteo, and we ended up doing a surgery. So I did stage surgery. I did a lift from L4 to S1 using titanium cage as an allograft. And then second stage, a few weeks later, we did T9 to pelvis, posterior spinal instrumentation fusion, and I supplemented that with an L3-4 prone lateral. For her, because of a coronal shift, I used the kickstand technique that I actually learned on this meeting from Larry Lenke. She's got an extra rod there hiding on the right side of the picture, left of screen, where basically we've put an extra screw in the iliac crest on that side, and before locking all the end caps, we've used that screw to distract off and basically kick the coronal balance across. So she's got T9 sublaminar bands and a vertebroplasty. She's had cement augmentation of multiple pedicle screws due to osteoporosis. She's had allograft and processed allograft mixed with demineralized bone matrix. So we lost access to BMP in Australia a couple of years back for these cases. Her SVA has been corrected at a year post-op to 83 millimeters. So not perfect. She's about a centimeter above where she should be, but a coronal shift is down to 43 millimeters. And I think it was much worse than the 8 centimeters or so beforehand demonstrated on that X-ray. Clinically, she's lumbar lordosis is 46 PI52, so she's matched, and the pelvic tilt is 26 degrees. So she's done quite well. Very happy with the result. But at 6 weeks after surgery, she, of course, got a DVT. So that's a tough thing to know as to whether doing A-lifts precipitated that. It was actually 6 weeks after her stage 2 surgery, so 8 weeks after her A-lift, that she got a DVT. It was treated successfully. But because she got a DVT, we got a CT of her abdomen just to make sure everything was okay. At 6 months, she had a little bit of residual leg swelling that had pretty much gotten better. And it gave me an opportunity to assess the interbody fusion, which to me looked pretty solid here already at 6 months through the titanium cages and a decent bone mass posterolaterally. Her clinical outcome scores were good at this point. So I was going to do a little poll on long fusion, and Ali was on Twitter earlier this week talking about this, but he was teasing us with results from a publication that I don't think is out yet. So we're going to go for a poll and see who does interbodies at all. So A is that you don't do an interbody or you rarely use them. B is a TLIF or PLIF at 5-1. C is an ALIF, and D is an AXI-ALIF, which I'm not sure if anyone still has access to, but I thought I'd throw it in there for those that like to reminisce. Wendy, has anyone?
I'm watching it. People are thinking about it. People are reluctant to say.
Yeah.
We got one vote for C.
For C, yeah. Have you seen an AXI-ALIF, Wendy? Did you ever see this device?
I don't think so.
So an AXI-ALIF essentially, I'm sure you've seen TLIF and PLIF and ALIF, but the AXI-ALIF was a device designed to be placed in the prone position, and it was done by a parasacral approach. And so you actually had to make an incision sort of closer to the exit to the bowel than most spine surgeons were comfortable with. And then you basically ran up the side of the sacrum and then used a slightly oblique trajectory to place a cage across the the S1 to L5 vertebral bodies through the disc. So it came really from the bottom up. Wow. In many ways, and it was heavily promoted for a while, but then got taken off the market. It had some good results, but overall a relatively high failure rate, and it was very, very hard to get out. So yeah, we don't see it too much anymore, but I threw that in there for people that are familiar with it. I don't know if it's even available anywhere in the world anymore.
Let me ask you a quick question in that regard. So again, as the radiologist, everything you're saying is good information for me to know what you do. When you say it has a failure, what fails here? What am I looking for when you say it's going to fail?
So the axial, I think because you didn't do a lot of disc prep, it wouldn't necessarily fuse across that space. It was a relatively narrow cylinder. It was basically a narrow, cylindrical device, a narrow cylinder that went across that disc space, and it was packed with either BMP or bone graft. And I think a lot of patients did fuse, but it was designed to be used in long constructs without having to change the position of the patient and without having to do a T-lift. So that was but they would sometimes snap. They would sometimes just not fuse and erode a bit of a hole in the sacrum, which could be problematic. And then if they didn't fuse properly, more stress on your screws and rods, and they may eventually snap at L5S1.
Okay, let me ask you a different question about this story. You said you knew from the beginning that she had a history of DVT, and she was probably on some blood thinner, right? Like Eliquis or Lovenox.
She wasn't previously, but we put her on blood thinners after ALIF. And then, a lot of the DVT patients, if it's a one-off surgical event and they don't have the, she had a knee replacement done 10 years ago. And so, she was no longer on it, but she'd had a history of a surgically induced DVT.
Okay, so that's interesting, because I'm asking, because that came up for a patient of my, my simple procedures today. Had this at DVT post-procedure a long time ago, but has been on blood thinners always. And is that the right thing? I don't know if that's the right thing, because it could have been, if he had gone to surgery with you today, he wouldn't be able to get it. So
yeah, look, I mean, I've got a team of great physicians that look after all these things for me, but to me, the evidence keeps changing. It's different from when I was in medical school in the 1990s to now. And so, look, I think this patient now, every time she has surgery, will be on long-term DVT prophylaxis, and I think she remains on anticoagulation at the moment. But the physicians may choose to actually wean her off that going into the future, because she doesn't have any residual symptoms. She had some mild leg swelling, and that's all gone away.
Okay, interesting. All right.
Okay, got another case. Again, it's not a big deformity, but just a few principles here to run through. This is a lady who had she's 61. She's highly intelligent. She's a scientist, and actually, I think she may even be doing some of the COVID work now in her lab. Although we don't have a heap of COVID cases here, we don't keep her busy enough. But there are a lot of swabs and other things going through her institution. She had a L5S1 PLIF and posterolateral fusion in 2015, and by 2018 she'd already developed substantial symptomatic adjacent segment disease, and she had two decompressions, laminectomies between L2 and L5, trying to really target the lateral recess in the foramen to deal with quite intractable left leg radiculopathy. So she was good for 6 to 12 months after this fusion, and then went downhill. And I think you can see here, there are a few issues with her spine. She's got about a 28-degree focal scoliosis. She's got a coronal shift of only 2 millimeters, but her SVA is 70 millimeters, which is really too high at 61 years of age. She's only got 28 degrees of lumbar lordosis versus a pelvic incidence of around 55 degrees. So for her, I want to go back to the future. I think if we could turn back time, it's sometimes nice. And this is the DeLorean, for those who aren't familiar with this wonderful movie, Back to the Future. I think, if you look here at what's been done, maybe the surgeon in 2015 was saying they did a great job. And I'll show you why that's the case. I don't think it's black and white here. So this was her presenting MRI before she had her PLIF done. And she's got a spondylolisthesis, grade 1, on lying imaging at L5S1. And look, what this shows is also she's got some multi-level degenerative changes throughout. She had the beginnings of a degenerative scoliosis here. I think the changes you see there at L2-3 are actually just a little bit out of phase. She didn't have really bad central stenosis at any level. She's got some lateral recess stenosis here at 5-1 with quite a severe facet arthropathy that you can see on the axial scan there. She did not have that I could find any erect x-rays before this fusion was done. So I think that's something that we all need to be aware of. And to me, you can do a beautiful PLIF, TLIF, ALIF, but you should be doing at least some form of erect x-ray before surgery, getting a rough idea of the patient's lumbar lordosis, their pelvic incidence. It doesn't necessarily need to be a full spine. That's my own practice. I'm lucky enough to have access to EOS scanning, but the principles of fusion to me are to try to pay respect to the patient's natural alignment and restore it as best as we can. So this is her immediate post-op x-ray, and just keeping the screws are well placed in terms of, they're in the pedicle. She's had a bilateral PLIF, big open exposure, and she's got peak cages there packed with allograft and BMP as well as local bone from the laminectomy. And if you look at her MRI, she's got 10 degrees lumbar lordosis, L5S1, and here she's got 14. So they've given her back about 4 degrees of lordosis in her initial surgery. If I go back, we look at this, she's got overall lumbar lordosis now, this was about 3 years post-op, of 28 degrees, and her PI is 55. So again, flicking forward, if you've got a pelvic incidence of 55 degrees, just rough numbers, you need about 2/3 of that arising from L4 to S1. Now, 14 degrees at L5S1 may be enough if you can get another 15 degrees from L4-5, but she doesn't have that here. She's already running a fairly flat disc there. So I think this is actually not a badly done PLIF. I'm not trying to have a go at the surgeon that did this, but the base of the spine is where we need to maximize our lordosis if we can. And I think that this operation, although it did relieve her problems for a little while, set her up for further issues. And if you look here, again, the midline PLIF approach, unfortunately, can lend itself to putting these screws in a little close to the facet joint. So the pick on the left is actually the L5 screws. And you can see the screw on the left of screen, the right side of the patient, is quite close to that facet joint. And this can really, again, help precipitate adjacent segment disease, adjacent segment degeneration. The cages are well placed. The S1 screws are well placed. So I think Matt Goodwin or Michael might have mentioned this previously. I've heard it as well. If you're not fixing a deformity, you are creating one. So some unknown genius said that. It wasn't me, but I think we have to respect the patient's anatomy for all these cases. So this was my fix. Looked at stage surgery. Again, I'm a big fan of stage surgery. I think it's safer for these older patients. I did a lordotic ALIF at L4-5 and L3-4 because she's solid at L5S1. And that CT there is from after the first stage where I rescanned her with the titanium cages in. We're not expecting solid arthrodesis there yet. I was happy with the amount of lordosis I created through there, but I thought we need a little bit more. I think if you go back, she's also got a bit of a lateral ascesis at L2-3. And so for her next stage surgery, a week later, I planned on doing a lateral fusion with an expandable cage and then T9 to pelvis at the back with Bedrock, which is basically a Sij Fusion device supplementing fixation around the S2AI screw, and use some cement augmentation and cranial sublaminar bands again. And this is her immediate post-op radiograph, which I was quite happy with. And I think this is 18-month follow-up. So she's done pretty well. She's back at work. She's really happy. No more leg pain, which was her main issue. Very mild, occasional lower back pain. Her SVA is actually back to 8 millimeters. So you could argue I overcorrected her a bit for age match. She's early 60s. She's got a minimal coronal shift. Her lumbar lordosis and PI match up, and her thoracic kyphosis has restored itself to 45 degrees, which is, I think, a great result because it just indicates that her spine is back in relative balance. If you go back here to how flat her thoracic spine is on the pre-op, that flat thoracic spine is a compensatory mechanism for the flattening of the lumbar spine, but it's not sustainable in the long term. And if we left things as they were, she'd just continue to degenerate and make it a harder problem to deal with in the future, potentially having to go up to T4 or T2 even. So I'm happy we got away with going to T9 here, and these patients all get long-term follow-up in my hands. They get 2-year follow-up, 4-year follow-up, and then I try to follow them out to 10 years. A minimum, because I want to see what happens to these patients. There are 2 incidences of PJK. One is that first 6 to 12 weeks, and the other is beyond 2 years. So I'm interested to see what happens in long-term follow-up to these cases.
I have another question for you, Mike. So
Yeah.
your last patient was the one that had osteoporosis, not this one, right? But this one probably does as well. Is that why she has bilateral hips, and is that why you use the cement, or do you use the cement on everybody?
I use the cement on almost everyone. I think we've had access in Australia to fenestrated and cannulated screws for a bit longer, and we've done some research on biomechanics showing that a cement augmentation improves pedicle strength pullout by up to 2 times. So the pedicle screw becomes a lot stronger. People are always concerned about if you can get it out or not. I've had to do it a few times. You can get them out. And in fact, putting the screw back in, sorry, just got a bit of sun coming in. I'll move a little bit this way. Putting the screw back into a cement mantle, if you upsize it, actually it gets a great grip. So if you've got a slightly loose screw in cement, which has happened to be maybe twice in 5 years since I've been regularly using it, you can actually take it out and you just put a slightly bigger screw and it gets a great grip. I know cemented hip replacements are not always big around the world, but a cemented hip replacement, you can actually do what's called a cement in cement revision for that. And so you can actually put cement in the cement mantle as long as the cement mantle is solid and revised at its described technique. And I have used a similar thing for these cemented pedicle screws as well. So they work quite well. This patient had a history of a possible inflammatory arthropathy, which can thin the bones. And she's had those bilateral hip replacements done. And those have been revised. It's hard to tell on the x-ray, but she had the ASR hip replacement. Are you familiar with that, Wendy? You remember the old ASR? So I know not everyone on the meeting is orthopedic based, but ASR was a hip replacement product that was designed for metal on metal bearing. And the patients ended up getting a lot of metallosis as a result of point loading on the edge of it. And so it caused the inflammatory reaction around the pelvic lymph nodes sometimes, and these local almost pseudotumors to form. So she'd had a lot of issues with that due to having bilateral ASRs some 5 to 10 years before her spine problems. And I think those are actually revision hip replacements.
For your cement, so is that the main, I mean, I'm trying to think, you're saying it's pretty good to put that cement in there, you usually do. What, are there any other downsides to doing it besides the people who say you can't get it out?
Yeah, so you have to, if you're putting, it's a small volume compared to say hip or knee arthroplasty, but if you're putting it in under pressure, you can sometimes get embolization of fat particles into the respiratory system. And so I warn my anesthetist when I'm doing it. We don't see too many changes.
Interesting. That's an interesting comment, because I used to do a lot of vertebroplasties and kyphoplasties, not in this situation, obviously, but just for fractures. And so, I mean, that is a known complication if we get it out into the veins. But I think it's extremely rare if you put it in right. So I would think for you, that wouldn't be an issue at all to get it in there, correct? I guess you don't have a fracture plane to be putting in. It's normal bone cavity. So there's not a lot of volume there for you to put the cement into. But that's interesting. A little bit different indication for doing that.
It's coming out through the tiny fenestrations as well.
Okay.
And so it actually works quite nicely. It usually stays pretty well contained. And your only problem you're going to have is if for some reason your screw's not in the right position.
Okay.
It could leak out that way. And I have had it sort of leak a little bit into the cranial disc, like used to happen in vertebroplasty with, and which I don't think is a big clinical issue, to be honest. A little bit of cement used to often leak in vertebroplasty into that cranial disc. And I don't think it actually affected outcomes much at all.
Yeah. Okay. Nice. Thank you.
All righty. I was just going to have a few words on the Bedrock technique. I'll go back one again and just show you. So this patient's had a Bedrock technique, and I don't know who's familiar with that, but it's an additional technique I use to secure the base of the spine. I'm lucky enough to have navigation, and so it makes the Bedrock technique pretty easy. What the Bedrock technique is, it's described by a few people, but David Polly's talked about it a lot at various meetings. It's essentially the addition of a sacroiliac joint fusion device to pelvic fixation to formally fuse the SI joint. And there's some debate about whether it's necessary or not. A lot of older adults, their SI joint barely moves. But I've seen enough patients, only a handful, but enough with some loosening of their S2AI screws, even with ALIF cages in, becomes symptomatic enough to need them either taken out or revised. So I thought I'd just say a few words on the Bedrock technique. Because the screws can loosen across a mobile Sij, the Bedrock technique adds good stability to that. And this is a patient who, before I was doing Bedrock, this is a surgery I did about 3 years ago, had an L4 pedicle subtraction osteotomy for, funnily enough, a PLIF done in kyphosis. I won't go through the whole case. Suffice to say, she ended up with a long construct from T9 down to the pelvis with the anterior column support, but got a CT scan because she was getting some pelvic pain. And I'll just see if this plays. So you can see the haloing here around the S2AI screws bilaterally, but the cages are solid and the S1 screws are solid. Oops, let's go back one. Play that video again. See that halo effect? So during the healing or fusion process, she's kind of loosened up her S2AI screws. And then the other interesting thing here is you can see the gas across the joint still. So it's still a mobile joint. You know, I don't know what Wendy thinks of this, but I've always used the lack of gas in a joint to indicate a potential autofusion or that a solid fusions have been obtained. And on a CT scan, if you can see gas in a joint that's meant to be fused at 2 years, it's probably not fused, in my opinion. I don't know what you think of that.
Yeah, sorry, I didn't know if I was unmuted. Yeah, I agree. That's what I would look for as well.
Yeah.
Sorry, go ahead.
So this is what I use for Sij Fusion. It's the iFuse 3D titanium 3D printed implant with a roughened surface, and you can see it there. It's a nice sort of picture of it, and it demonstrates substantial bone on growth, in growth, through growth. It's got some good evidence behind it for isolated Sij fusion, where you tend to use 3 or maybe 2 implants across the joint. When you put an S2AI screw across that joint, it gives it some inherent stability initially, but it doesn't control rotation because the screw is shaft is circular with some threads. You know, there's still that little rotational movement at the Sij. So what this does is it allows you to get some more control of that movement with effectively a triangular implant that will stop that rotational component. And you can pack it with graft after you've placed it. And there is, from LinkedIn, Bernardo's got a great paper he's done with his colleagues from the Barrow Neurological Institute on from the BNI Spine Lab, and he's done a whole bunch of cadaveric work on placing an ALIF, S1 screws, S2AI screws, and with the addition of triangular titanium implants, or Bedrock type technique, and shown that there were substantial benefits here in terms of reducing the stress on the S1 screws and on the other parts of the construct. And so this is a great paper, and it's just been published in JNS.
Hey, Mike, so when you do the 3D printing, for someone who doesn't know, so what do you use? What does the machine use to create it?
So there are a whole bunch of 3D printing types of equipment available. I've only ever seen the ones that print in Peak. I've never gone to visit a factory that does the titanium ones, but I think they're relatively straightforward in that you can get a lot of different sizes now in the titanium implants, in particular because of 3D printing. And so you just get a range of different implants. And the ALIF cages I use in the cases I was showing, and even in this case back here, they're all titanium 3D printed cages as well. And because of issues with inventory in the past, we haven't always had a heap of sizes, but I think now with the way 3D printing's improved, companies can produce a heap of different sizes of implants for you. And then you can go and do customs, and they take 4 to 6 weeks. If you need something really, really big or really small, they take a bit of time. You need to get a CT scan, but the CT scan then feeds into the system of 3D printing, and out pops your 3D printed device in titanium.
That's what I was going to ask you, if they're really personalized for everyone from their CT. And instead, so it's kind of both. You're saying there's some that are already different sizes and you choose, but then some people get their own from their own scans.
Absolutely. And look, in Australia, the insurance companies haven't quite caught up with the do your own one because they're really expensive. And so we have to apply for special permission to do that. But I think it's coming. I think it's on the way. You know, I'm really, it's exciting technology actually to be able to customize implants for patients. And it's already somewhat there for a knee surgery. You can do custom jigs for knee replacement and customize implants. And there's a couple of companies around the world that have been leading it. One is a little company in Australia called Anatomics, who's done a lot of custom-made titanium and implants, and they've done things like reconstructions of chest wall for tumors. So they'll print a titanium sternum that then attaches into the ribs, as well as they'll do upper cervical stuff as well. So you can get a lot of cool stuff with 3D printing these days.
Does insurance pay for any of those things?
Sometimes it depends on your insurance company, and I don't know what the situation is in the US or other parts of the world. I think some places with mainly public systems will have a bit more luck, like Canada and the UK. But we can get them every now and again, but it is a little bit challenging, and that's why having a huge range of sizes on the shelf has been very helpful.
Okay.
All right, I've got another quick case. If there's no questions coming through on the chat.
Yeah, not yet, just from me. They know this stuff that I'm asking. I get to learn today.
This is an old case, but I just wanted to show it because it's a really interesting case. So this is shifting gears a little bit down to kids. And this is a lad that I looked after who was 12 years old. He was Indigenous, and our Indigenous communities in Australia, a lot of people live in the big cities. Some live quite remote, you know, many, many hours from medical care. But this lad was sort of in between that. He was in a near rural area. And he'd actually been diagnosed, I think, in utero through ultrasound with a congenital spine abnormality. So I get these referrals still from the high quality ultrasounds. You can see sometimes congenital vertebral anomalies in children in utero. So I've done had to do some counseling, which was a new part of my practice for me in recent times because of this. But this lad had a known congenital block vertebra at T1112 with a really what looks like a pretty mild congenital kyphosis and a mild deformity. And this is a CT from 2011 when I think he would have been only about 6 years of age then. So at 6 years of age, this was the appearance of his spine. And sorry, I haven't got all the slices, Wendy, but what do you think?
Oh man, from that, I don't know what I can say. I mean, that if you hadn't told me the history from this one picture, I probably wouldn't have known it was like a block, like you said. It is abnormally shaped, obviously, in this picture. It does look like you've got a little bit of ankylolisthesis and some disc bulge, a little bit of canal narrowing.
Yeah,
and above, but
there is a little bit of canal narrowing there.
You got quite a bit of space between your spinous processes, though, down there.
Yeah.
I'm pointing with my mouse, even though you can't see it. Pointing to what I'm talking about, but I think you know what I'm talking about.
So in 2016, this was the shape of his spine. I apologize for the quality of the radiograph. This is an erect picture, and you can see there perhaps his kyphosis is a little bit worse. He's got some pain, and now he's getting a bit of tingling and numbness in the legs. You know, he's still running around doing normal kid stuff, but he is definitely complaining of a subtle increase in problems. And this was his rect X-ray, which to me doesn't look disastrous. You know, he's got a mild kyphosis there at the thoracolumbar junction, and overall otherwise well balanced. He didn't have a major scoliosis at this point. So we observed this at this stage, but got an MRI as well. And this is what we found. So this is a bit more for you here, Wendy. I've got a few slices here of his MR. He's got a few issues, some of which, being an orthopod, are not in my domain, but still need to know about them.
Yeah, I was going to say, even from that X-ray, I couldn't see it terribly well, but it did look like that kyphosis or the listhesis had increased on that X-ray quite a bit. So this,
absolutely,
yeah, this picture doesn't surprise me at all. I thought it was even going to be a little bit worse than this, but yeah. So this is an interesting phenomenon. I don't know if that's what's going on here, but let me ask you. Sometimes we have a cord here that isn't compressed. You still see a CSF, right? In front, well, maybe not in front, but in back of it, but it's draped over that kyphosis.
Yeah.
And it's interesting because radiologists will say, you know, there's no canal stenosis, there's nothing wrong here. Obviously, I'm not talking about the syrinx yet, but I was recently told by one of our neurosurgeon, spine surgeons, that can have just as much effect, that draping, as if it was actually compressed. Because in essence, it is, with that, you know, the pressure on the front aspect of it. I don't know if that's what's happening here, but you obviously have enough of a pressure that is causing CSF flow disturbance in the central cord canal to cause the syrinx. Several syrinxes, geez, whatever, more than one.
Yeah. And what do you reckon about the position of the conus here?
Oh, yes. Okay, so you have a low conus, so it's probably tethered as well, down, right? So you've got at least two, if this counting, if I'm counting correctly, and this is 5, it's maybe at 4.
Yeah.
The conus is at 4.
I think it's a 4. So this is a problem because you've got a kid whose deformity is definitely increasing, I think. It's subtle, but this lying picture looks worse than the CT. And certainly when he stands, I reckon it gets a little worse. And so I'd had a long talk to the family and the lad about surgery and getting this dealt with. And look, I think when you're looking at a deformity like this, you probably don't need to do a really big correction. You want to keep things fairly focal. But I like to get the cord dealt with first, because to me that's safer, is to get the neural elements dealt with first. And so I'd send him to my neurosurgical colleagues for a planned detethering in a stage fashion. So do that first. Detethering, and then and see what happens. And I wasn't really that aware until I had detailed discussions with them that when you detether a cord, it doesn't rebound back up. You know, my very basic impression was that a detethering would cause the cord to immediately go back to where it should be, but it basically it doesn't do that. It might go up a little bit, but not much. And it's sort of allowing, the detethering just allows more plasticity and more change in the, allows you to change things more in the spine without stretching the cord. So that was my plan at this point, and then to look at a short segment, probably combined anterior posterior fusion for this young lad. But unfortunately, the lad and his family had a few social issues, and he didn't attend multiple appointments with the neurosurgeon, then got lost to follow-up. So this is age 12, 2016. And then in 2017, he actually came back in via a peripheral emergency department. So he came back in unable to walk. And whenever he stood up, his legs were really weak. And lying in bed, he had clonus and hyperreflexia bilateral lower limbs. His upper limbs were okay. But clearly, there was a difference between the standing and lying position. This is his new X-ray. So he wasn't detethered at this point because we lost him to follow-up, and he's progressed his congenital kyphosis to essentially almost a spondyloptosis there. And this is as you can imagine, causing fairly significant cord compression. He's developed a scoliosis associated with this that he didn't really have before. And this is a CT scan, again, showing the block vertebra above the kyphosis, where he's ridden over the top. And there's no infection here. He's just got rapid progression of deformity. And this is why we consider congenital kyphosis to be really dangerous. This is why I wanted to try to fix it before. Sort of as soon as I knew about it, we put a plan in place. You don't want to worry kids and their families, but really want to try and get these done if you spot them, because this is not the only case of congenital kyphosis I've seen develop problems during the adolescent growth spurt. So this was his CT. We got him into hospital, and because his lying power was reasonable, he had some preservation, we went with the plan of getting him detethered first. So we released his tethered cord. This was the MRI pre-release. I planned a 2-week interval before doing an osteotomy at this level and a posterior spinal fusion. And unfortunately now, if I just take a step back, with that type of scoliosis and kyphosis, you're looking at a much longer fusion than just a short segment instrumentation that I planned back in 2016. And this was his long spine views after his tethered cord release. So I took him to theatre to do a posterior procedure, and we got reliable somatosensory evoked potentials. This is our neuromonitoring I use for all deformity cases. But we had really poor cortical motor evoked potentials on the left. They could just pick them up, but my techs really couldn't get great signals on the motor evoked potentials, which are more sensitive than the somatosensory evoked potentials in terms of deficit. So I placed screws above and below with no adverse events and no breaches. I was really happy on fluoroscopy. And basically in the prone position when I was placing screws, he dropped the cortical motor evoked potentials that I had down to nothing. And so he lost his motor signals altogether, just from a bit of pressure from putting in the instrumentation. I took all the screws out, palpated, made sure that they were okay. I could feel the medial wall on a lot of them, and I knew they were fine. So I put them back in and did a laminectomy as planned for decompression, palpated saw the cord, saw the dura. There was no CSF leaking, there was no hematoma. I palpated the medial wall of all the pedicles nearby, and it was all fine. We elevated his blood pressure right up, and his right side cortical motor evoked potentials returned to near baseline. So they recovered in theatre. The left returned, but remained low at about 30 to 40%. The challenge here was, if this was a pure elective case and he had no deficit before surgery, I would have probably taken everything out, bumped up his blood pressure, woken him up and got an MRI. The challenge here for me was that this is a young man who basically had a deficit. He couldn't walk. He had some preservation of power when lying, but I didn't really want him to leave the operating table with a potentially unstable spine. So I had to make a choice at this point, as the right had returned, to leave my implants in. I did not do an osteotomy. I used titanium rods, so soft rods, to not overcorrect him, and essentially did a fusion in the position he was in on table. And then, unfortunately, MRI post-op, heavily obscured by artifact, still shows the low-lying conus. This is his CT post-op, showing a wide laminectomy across the segment involved. And this is just a rundown of his implants. I used hooks at the top. And you can see his implants are all well placed. And this is what I spent a bit of time agonizing over during surgery. But there was no problem with any of the implants. You can see the laminectomy through there. Crosslink, and then a few more implants. So that was where he was. And so post-operatively, he woke up with a flaccid left leg paralysis, but a normal right side. So his right was better than pre-surgery, and his left was worse. But he had near normal sensation. So I knew the signals were getting there. His clonus was reduced. And he had hyperreflexia pre-surgery, so indicating a cord level problem. But then he had normal on the right after this operation and no hyperreflexia on the left, absent reflexes. So he's had a change in his neurostatus. And clinically you go, well, he's worse, but this is not a cord level problem anymore. This is more of a peripheral nerve problem. And so my first instinct was to blame the neurosurgeon who did the untethering, but I don't think that's fair. But I then talked to one of my other colleagues, who's another female neurosurgeon, and she said, you're 100% right. It's going to be a peripheral nerve stretch issue. And you know, she was spot on because, oops, sorry about my language. I had to sit him out of bed. And we'd been keeping him lying down, worried about this neuro deficit. But we sat him out of bed and we kept his knees and hips flexed in bed to 90. And we sat him out of bed. And we realized that when he sat out of bed, his power was coming back. So by just taking the stretch off the neural elements, and I think there was a real stretch issue here to the nerve roots from the combination of tethering, surgery, everything that had gone on. We just saw recovery, didn't change anything, didn't go back. I sent this case around the world to my friends, and some people said, go back, other people said, don't go back. No one knew what to do. And so at post-operative 10 days, he had near full power, but we kept him in an AFO. And by 6 weeks post-op, he got full power back in that left leg, which was a great outcome. So I think this was actually just a demonstration of a clinical exam really helping, and just a really simple maneuver like taking the stretch off the neural elements and keeping those knees and hips flexed, which is what I do for my high-grade spondy corrections as well post-operatively. I really try to keep those hips and knees flexed when possible when resting in bed or sitting. And this was his follow-up in 2017. So he's got a stable construct. The kyphosis is not completely reduced, but neuro intact and not progressing anymore.
Mike, do you have an MRI? Because I would think that if not you, then maybe the neurosurgeons would like to see if the two syrinx are gone after the detethering, because that's important for function too, right?
Yeah, I don't have one. I think he, again, he doesn't always come to follow up, and he doesn't love the MRI scanner. So as he was doing well, he may not have had another one. I'll see if I can find out.
Yeah, because that's a fascinating case. I mean, it's an interesting case, and your story, your journey through that case, also how you figured it out.
Well, I didn't have any gray hairs or bags under my eyes before that case. And,
this did it.
That's definitely, these things build up in life, these pediatric cases. So yeah, sorry, I'll just move my computer a bit. The sun's coming in again. So I reckon that's all my cases for this session.
Well, we can ask you a little about this. How old was he here in this last? How old is he?
He's 13 now, so this is post-op about 6 months.
Or I mean, but did you say, how old did you say he is though?
He's 13, was
13?
X-ray, yeah, 13, 1-3, yeah.
So then he'll keep growing?
Yeah,
and will you have to do anything with this as he grows?
No, so look, any fusion, definitive fusion above the age of 10 doesn't usually have major issues in terms of trunk height, in terms of major cosmetic issues with shortening that section. Certainly early onset scoliosis or kyphosis before the age of 10, big challenges. And that's a whole nother talk. We could spend several hours on that, because the growing rod constructs that you use for that with regular lengthenings have huge complication rates, but are probably the best of a bad world. I think, again, for this lad, it would have been really nice to do that when that was much easier, when he didn't have a deficit, and keep it really short, a short fusion. But unfortunately, he ended up in that situation where he really, from a congenital deformity, developed a progressive neurological deficit. And I suppose the take-home message here is that not a lot of patients with congenital scoliosis or kyphosis, even with the abnormalities that can go with that, with the cord, I mean, there's a high incidence of those problems. But not many of them will develop progressive neurology. It's pretty unusual. But the ones that I find do are the congenital kyphosis cases.
Interesting. Wow. Those were all great cases, but I'm still fascinated by this one.
Yeah.
That was a great one.
I'll see if I can chase up a long-term MRI. I'll ask.
Sounds good. Yes, please do. Well, if there are any more questions, yes, everybody's thanking you for your cases. Great cases. Yeah, those were fantastic. And if you post some of these on Twitter, if you haven't already, we'll see them again. And then also, of course, everybody can watch this on YouTube, and we'll make sure everybody who couldn't be here today will see this. So, but we'll go ahead and we can adjourn for today unless you have any last comments.
No, Wendy, I'd like to say thank you. And look, yeah, I think always happy to take questions. And
you can find him on Twitter and LinkedIn.
Yeah, Twitter and LinkedIn. Just ask me anything. Occasionally you'll get a suitable answer. Okay.
Thanks so much, Mike. That was great. Those were really interesting cases. And thank you for teaching me, letting me ask all those questions too. So we'll see everybody next week, next Thursday, 6 o'clock p.m. Eastern time.
See you then. Thanks.
All right.